right, everyone. Well, thank you for joining us. We'll go ahead and get started. It's 12:01. So we have today here Dr. Sonoda here to talk to us about behavioral strategies for addressing HIV stigma. So as a brief intro for Dr. Sonoda, he is an associate professor in the Department of Family and Community Medicine at St. Louis University School of Medicine. He currently serves as the Family Medicine Clerkship Director, the Addiction Medicine Concentration Director in the residency, and the Addiction Medicine Fellowship Core faculty at SLU. He completed his family medicine residency and HIV primary care track at the University of Pittsburgh Medical Center, Shadyside, and the Addiction Medicine Fellowship there as well. And he provides full scope practice focusing on addiction medicine and HIV, currently serving as president elect of the St. Louis Academy of Family Physicians, the Education Commission co chair of the Missouri Academy of Family Physicians, associate editor of the Curbsiders Addiction Medicine podcast, and also SCFM's faculty development workshop instructor. So I'll pass it over to you, Dr. Sonoda. Thank you so much for joining us.
All right. Thank you so much, everyone, for this invitation. I'm going to share my slide and hope you can see this. Okay. Right now, can you see my slide? Okay.
Yes.
All right. Thank you so much. Yeah, I'm glad to be here. I know this is a webinar, so it's not the workshop or something like that. So I won't didn't incorporate interactive portions much, but I love to hear about your, opinions, views, and some insights. So I may pose some questions, and it'd be great if you can unmute yourself or put some comments on the chat box too. First, I want to start. Um, if you can put on the chat, that'd be great. How many of you see patients with HIV infection at least like once a year? Or have you ever seen? It'd be great if you can share your experience. Yes. Oh, I think Vadela, you wanted to just say yes? Okay. You can unmute yourself too. Okay. Anyone else? Okay. Oh, thank you for the chat. Yep. And I do our practice. Oh, very frequently. And oh, good. So someone managed some education stuff. Then have a panel of 8 patients. Okay. Okay. Good. So I wanted to make sure you see the patient with HIV as a part of your practice and kind of get the sense. So okay, thank you so much. So I put some basic information given the audience information that I got. I'm sorry if it's too easy for you at the first part, but I thought that it's good to be on the same page for the part of fundamentals knowledge around HIV. So let me give some lectures as well. So today I start from some HIV basics and mainly to give some education around the HIV. And then I talk about some actions and then I do case discussion and then Q&A at the end. All right, objectives. So by the end of this session slash webinar, I hope you'll be able to explain the differences of HIV, HIV PrEP, and HIV PAP, and also be able to identify at least 2 strategies to address HIV stigma. So this is a quote. This journey of education and the breaking stigma around HIV is something that will have a legacy everlasting. So as you can see, and as you know, this is not something that we like check the box. All right, I got this. It's not like that. It's not that simple. It's quite complicated. It's like a lifelong learning process, and things change over time too. And so I hope this webinar would help you better understand and be equipped with some skills. But it's not the end. I hope this be just part of your learning process. Okay, so first I want to start from my journey into this field. So I started my HIV primary care track in residency, and that's something I'm very passionate about. And then, HIV comes from two ways, right? One from sexual contact, the other one is addiction medicine. And I thought that given the sensitive topics and the stigma around HIV addiction, I thought that it's be good for patients to receive care from one individual. That's why I got the addiction medicine fellowship training on HIV so that I can treat the patients through my skill, like primary care, HIV addiction, and also I can treat the Hep C. So that they don't need to share some sensitive information with multiple random doctors. Right now, I provide primary care at one of the clinic within the St. Louis University Hospital, and also I provide addiction care in downtown. Okay, so I start from case, and then we go back to the case. Okay, so think about how you want to approach. So this is a case one. You arrived to a family reunion picnic with your sister, who recently shared with the family that she was diagnosed with HIV infection. As you make your way around to say hello and offer hugs to family members, your cousin hesitates when greeting your sister, commenting, "Am I not going to get it? Am I?" The question is, the concern is she may get the HIV by hugging. So how do you respond? What to do? Think about that. We get back to the case at the end. Okay. Case two. Marcus slipped the PrEP pill into his water bottle at the weekend get together with friends. When his roommate's girlfriend noticed the little white pill, she laughed and asked, "PrEP? So you're planning to sleep around with everyone here?" Marcus felt everyone's eye shifted to him. After that night, Marcus hid his pills and stopped talking about PrEP, even though it was keeping him safe. Think about that. How do you want to respond? So if you just read this, it's like kind of very shocking, but it's happening. And it's pretty common. And I thought that this is why I'm here and talk about the stigma today. All right. So some HIV basics. All right. So in the United States, right now, approximately 1.2 million people living with HIV infection, and it's estimated that 13% of patients with HIV infection don't know their status. So they don't know that they have HIV infection because in the first couple of years, they don't present any symptoms at all. They don't feel it. Same with other STDs. And so that's why screening and prevention are very important. And then still 30,000 cases each year in the US. Again, it's not curable. So as people get, the number would just keep accumulating. And there are treatment out there, oral medications once a day, or now the injection options are available too. And also there are some different guidelines around the cancer screening, and also there are some unique primary care needs. So that's something the patient need to know, and doctors need to know too. Okay, HIV PrEP. So HIV PrEP is PrEP pre-exposure prophylaxis. So this is something to prevent against HIV infection. And this is for who don't have HIV infection yet, but at the higher risk for getting HIV infection. And it does not protect against any other STDs like chlamydia, gonorrhea, trichomonas, or syphilis. And this medication and treatment is highly recommended by USPSTF. This is the United States preventive, preventive the task force, and they put the grade A recommendation. This is highest grade recommendations that they can put. So that mainly because this medication has a safety profile and also it can effectively prevent against HIV infection. That's why they gave grade A. And it's highly recommended, at least to talk about it when doctors or healthcare providers identified any potential risks. Okay, so now I'm going to talk about some health disparity and some gender and racial gaps in this area. So on the left side, this is a pie chart of distribution of HIV infection by gender. So as you see, men has maybe 80% and women maybe have 20%, right? And this ratio should match with PrEP ratio by gender, right? It's not. It's obviously not. Predominantly men get more HIV PrEP. Same with race. So this ratio should match with HIV PrEP ratio, right? It's not. It's not. And get to more details. So you don't need to remember this, but the bottom line, if PNR, a PrEP to need ratio is low, there are more unmet needs. So if you look at that by gender, men has 11, female has 4, and by race and ethnicity, white has 18, Hispanic Latinx has 4, and black has 3. Again, if the number is low, there are more unmet needs. And then if you look at the PrEP rate by race, if you just look at this figure, it looks good, right? Over time, PrEP rates been going up across races. All good. No issues at all if you just look at the table. But if you look at PNR by race, the gap is widening. Again, if PNR is low, there are more unmet needs. So obviously, if we just let it go, things get worse. You can see the trend, right? And so something happening, and we need to work on this. And there are lots of barriers to getting the HIV PrEP. Stigma is real, as I touched on a little bit on the case. When someone taking pill for the PrEP, they often viewed as having multiple sexual partners or sharing needles because or at higher risk for various reasons. So that's why it's stigma around that. Just taking HIV PrEP to protect against HIV infection for themselves and the community. And the cost is a concern too for the patients and the clinicians. And because many people don't know that actually PrEP can be provided in a very reasonable price. But there's so many community programs out there, but we just many people don't know. So the cost can be a very concern too. And knowledge for the patients and the clinicians, because many clinicians don't feel comfortable to talk about that. And also patients often don't see themselves at higher risk for HIV infection. So knowledge on both ends are barriers too. Okay, moving on. So something I wanted to touch on is like stigma slash stereotype. I mean, the question is why is that, right? Like, why do certain people get the PrEP or HIV treatment and why other people don't get? I think the stereotype is a part of it too, because at the beginning of HIV pandemic, mainly the HIV infection spread through the gay communities, and that's why there's a stereotype around that. And so the many people still view HIV as sort of some certain populations conditions, and they don't view themselves at high risk. And so this is one poster, but now it's been getting better, so we don't see this kind of posters. But till 10 years ago or so, whenever we see the prep, we only see the gay man on the poster or flyer. So just imagine if you're a woman, what do you, how do you feel, right? You may not feel like you're indicated for HIV prep, right? If you're trans, you may not see that, right? And and also the tricky part is that there are a couple of HIV prep medications, but the uh, only one out of three medications is indicated for people with uterus and like or women, however you want to call. And that's why still the PrEP is being viewed as the medication for men, only for men. And there's some rationale, but I will skip that here today for this context. So this is the flyer for the SCOBY, and then this is, commercial for the injection type, right? How do you view, right? And if you're not the man. And so now the CDC and other organizations put in the efforts into addressing this stigma slash stereotype around HIV PrEP, and so that the various people and people from different backgrounds can see themselves for that they can be indicated for HIV PrEP. Okay, I have a little bit more education and then I go back to um, the case stuff. So indications wise for HIV PrEP, so if someone have a recent STI, syphilis, gonorrhea, chlamydia within 6 months, or inconsistent condom use, or active drug use, or someone with HIV infection in the partner. All right, it's a quiz time. Has anyone seen this before? And if so, it'd be great if you can share what that is. You can mute yourself or on chat too. Yes, thank you so much. Yes, undetectable means untransmissible. Yes, so if HIV infection is under control, meaning undetectable, uh, there's in theory, the patient, the partners or whoever have contact with will not get the HIV infection. So this is the public message around the HIV infection. Okay. And then next one is the PEP. So this is post-exposure prophylaxis. And so this is an emergency because the patients need to start the medication within 72 hours after exposure. For PrEP, it's not the emergency at all. Like, you have a discussion and then talk about whether you want to do it or not. But this one, it's emergency. So you have to have timely treatment. And the regimen wise, basically the patients take HIV treatment for 28 days and then complete. So the main difference is basically you take the same treatment, but for the HIV patient with HIV infection, they take this medication in their lifetime till innovation happens. But in this case, the patient take only 28 days, and then once you complete, you're done. So that's the main difference. Okay, so I hope I gave you a little bit of education and I hope you learned something new from my lecture around HIV basics. Okay, now I'm getting to some action stuff. Okay, so now you get some facts, right? Because this is very critical when you address the stigma because you're the one to educate people. So I hope my lecture kind of get some skill and knowledge to help you educate people. And also you need to learn how to talk about HIV too. And also when someone say that kind of word on the cases, like you cannot like be like angry or very defensive about them because they don't have any like they may not intend to harm people. They may just react into it because at the same time, from the individual standpoint, I kind of who said that kind of words, yeah, I kind of get that too because you don't want to put yourself at the risk for getting HIV infection because people know you cannot treat HIV infection right now. So I totally get people become very sensitive in the context of HIV infection. So I start from there. And then first, the second piece is wording, how to talk about that. And so, for instance, instead of using AIDS, it's better to use HIV or HIV and AIDS. So AIDS is part of HIV vaccine complication. So AIDS is something that patients get when their immunity gets so low, and then they become prone to getting severe infections that the like general populations would not get because of their normal immunity. So having HIV infection does not necessarily mean AIDS infection, AIDS. So it's important to distinguish between the two. And instead of saying like to catch or pass on HIV infection, as a professional, it's better to use acquire or transmit HIV infection. Instead of saying risky behavior, instead say people who engage in behavior such as unprotected sex or something like that, that may increase their chances of getting HIV infection. And you may have heard of this, but it's like a person first language. Instead of saying AIDS patient or HIV patients, say persons or individuals with AIDS or HIV infection. That can indicate that that person is like HIV person, like it's HIV is just part of their characteristics. Okay, psychological safety. I touched on a little bit, but uh, it's good to get the permission maybe at the beginning. Can we talk about that also? And so that uh, the the receivers or your friends or family be ready to get some education. And then, as I mentioned, like fear is real too on both ends. On journey, you know, this is very sensitive information for them. So please be careful when you talk about that in front of that individual because it often involves some sensitive and traumatic history and background for them. And when you talk about that, make sure to have privacy too around this context. Okay, going back to case one. So I talk about that a little bit, but if some of you can share how you want to approach, I appreciate it. How you like start the conversation. I think I said like maybe start from permission, but once they give you permission or they agree to talk about it, how do you approach? What do you say? You can mute yourself or put on the chat. Oh, yeah, I got the chat comment. Do we still use PLWHA? I think you're referring to people living with HIV infection, right? Yeah, yes, we still use that a lot. Okay. Is anyone tried that? Okay, thank you for your comment. I think the cousin needs psychoeducation. Okay. Uh, Jamie, if you feel comfortable, do you think you can elaborate on that? Sorry, sorry, kind of have you on the
Sure,
spot.
yeah.
Thank you.
Yeah, you're fine. No, you're fine. I like asking, I'm not going to get it, am I? Is like, do you understand how you acquire HIV
Right.
AIDS, right? Like giving some psychoeducation on that, and then also talking to him about like, when they have that education, hopefully they're not going to ask questions like that. Maybe they'll understand that that's rude or, whatever. I'm not really sure what the tone of voice would have been for this cousin. I think that would tell us a lot too.
Mm,
But
right.
clearly, they need some psychoeducation about how it's transmitted or how they can acquire it. And then also, maybe some education around how to interact with people who do have that diagnosis.
Great. Thank you so much for sharing. And also I get the comment, like, I think I'll ask them if they know the transmission methods of HIV or not. Yes, exactly. Because again, they may just don't know, right? And I had a very similar, like, a real experience too when I in the hospital. The one of the nurse asked me whether they can touch a patient or not when they have HIV infection. The patient had HIV infections. Yes, you can touch, right? And so it's just very much misinformation and lack of knowledge around HIV infection. So this is just my, like, examples, and there's no, like, one fit for all. And as Jamie mentioned, it depends on their tone and situations as well. But you can maybe, of course, you maybe stuff from permission or anything, but like maybe you can do the model of positive behavior, because if you hug, right, like you can, like, imply that you can hug people too, right? And so maybe you can do some the model of positive behaviors and talk about HIV basics. That's why I gave you lectures at the first part, and then offer to have some conversations and answer any other questions. Because just imagine if someone doesn't know that mode of transmission, it's very likely they don't know other HIV basic information still. So this is the great opportunity to educate that individual. And then if needed, you can follow up the conversation too. And again, I'm not um, get upset or defensive about when I hear about this kind of statement, because again, I kind of get their standpoint too. Yes, very scary of taking care of the patients with HIV infection, especially if you don't know how to get transmitted, right? So I think, yes, I love to talk about this, but at the same time, it's important to understand where their fear is coming from too. Okay, next case. Uh, any comments about this case? How you wanna address? Yeah, educate on what the PrEP is, and say HIV PrEP can be for anyone, regardless of their sexual activity or number of partners, as it can provide an extra sense of security for someone and everyone who takes it. That's right. That's right. Yeah, because even if someone doesn't have multiple partners and just have a new one partner, still have a chance to get the HIV infection, right? Great, thank you. Okay, I will share some tips that I came up with. Uh, Maybe like a calm and stay like informative, mainly for education purposes. Like maybe you can say like PrEP is just a medication to prevent HIV infection. It's like using sunscreen to prevent sunburn. It does not say anything about my personal life. Or, be confident and be direct too when you educate. So that's common misconception. Kind of acknowledge their lack of knowledge, and taking the PrEP is about health protection, not judgment about anyone's choice. And then lastly, supportive and inclusive. a lot of people think that kind of, doing the generalizations about the lack of knowledge, but actually PrEP is for anyone who wants peace of mind about HIV. I'm happy to share what I learned if you're curious, like instead of giving so much information, like give the direct answer first, and then if they want to know more, you can offer, and then if you just fine with it that moment, you can stop. And that's how I approach. And I think yes, it depends on the context and depends on their tone and circumstances. But just quick teaching makes a huge difference for that individual too. Okay. All right. So I hope at this point you can explain the differences of HIV, HIV PrEP, HIV PrEP, and also I hope you learned some strategies to address HIV stigma. Yes, as I mentioned at the very, very beginning, this is not um, straightforward or simple issue. This is very much complicated, and yes, it depends on context, depends on the individuals, like a relationship and circumstances. But I'm hoping that I gave you some framework and some knowledge when it comes to HIV stigma in your lifetime, or private time, or your professional time. All right, now I'm happy to take any questions.
I'm curious if you have any suggestions for in your work with patients who have HIV. Are there themes that you see amongst your patients that you'd like other clinicians to regularly address during their conversations with these patients, whether it's adjustment to the diagnosis or psychosocial factors that we can support them with? I'm curious what themes you've noticed in your care.
Oh, thank you so much. Yeah, I think that at the very beginning, they be shocked the first.
Mm.
Like, um, I think I hear that some colleagues give a call when they newly diagnose a patient with HIV infection. I highly recommend clinicians to inform the patient of new HIV diagnosis in person at the office.
Mm.
Because just imagine, when you give a call, right, and then you ask, are you in a good spot? Is this good time? Just imagine that someone maybe in the parking lot, or someone maybe in the living room, in just in the middle of family gathering or friend gathering. Like, what do you do? How does that individual respond to that serious lifetime diagnosis, right? If this is like, I don't know, chlamydia infection, yes, it's shocking, right? Because that's very likely your partner cheated, or yes, it's very shocking.
Right.
But you can take antibiotics and boom, that's it. That's it. You don't need to even forget in next year, right? But HIV infection, it carries with your life, and that's why I highly recommend every single clinicians to have patient come in the office, and then you know tell them the diagnosis, and then educate them how much they know, and then fill in the gap if they don't know some basics, and also tell them the importance of taking the HIV medications, because nowadays, because of advance in medicine, as long as they can take the medications every day as prescribed, their life expectancy gonna be about the same with people without HIV infection. The flip side, if you don't take the medications for whatever reasons, because of stigma or lack of access, or like you name it, their life can be shortened because of various complications on them. And so I talk about that, and also some community gathering and some peer supports around the HIV too, and that's what I do sometimes when I newly diagnose a patient, and so that they can get some support from their peers. And that's what we do in the addiction too. Addiction is like, they get that over time, but it's still they get lost what to do, and so the peer uh, in the addiction medicine plays a critical role as well as peers in HIV infection. Sorry, it's kind of long answer, but that's what
Great.
I think put like, most emphasis on in the context of educating my colleagues.
That makes sense about thinking about an in-person conversation versus a phone conversation. It gives you much more ability as the clinician to understand your patient's response and support them with whatever their reaction or interpretation is.
Yeah.
Do you ever talk with patients about how to share their diagnosis with their loved ones?
Yeah, it's kind of yes, I talk about that because depending on the state, but of course, just through the common sense, they need to tell them, right?
Sure,
I
especially any sexual partners, for sure.
yes, and so I tell them to let them know in person instead of text or phone call right after the diagnosis, because the partner would get upset too, right? And so I think, and then I provide like extra materials, like patient education materials about the HIV, and so that the patients can refer to some resources when they like teach back, almost teach back, right? They kind of share
Mhm.
what they learn from HIV infection, and also, as you know, when we get so shocked, our brain stops, like we nod, right, but not listening really, like you cannot process much when you get that kind of big news, and so make sure to provide some the material resource that they can go back to once they settle down.
That's
Yeah.
looks like we have a question in the chat from Raymond too.
Yeah, thank you. Let me read. Curious about the experience for working with the partner or families of people with HIV infection. Do you have any other recommendations or advice that can share with us? Mm, I think depends on some context, but mm, especially for partners, yes, Mm, they should get tested. I mean, I start from there, and then it takes 2 to 3 weeks to get detected. So test them first, and then maybe like test them again in a month or so, and then you kind of sure that they get the HIV infection or not. And if not, it's up to them, up to the partners, whether they would take HIV PrEP or not. Because in theory, once their HIV infections become under control, and if they're monogamous, they won't get it. But in theory, but for instance, let's say the patients forgot to take the HIV medications for a week, and then HIV get detected and they have sex and then can get it. And so in theory, yes, in the assumption that the patient take the HIV medication every single day in their lifetime, yes, it's important, but something happens all the time, right? And so if someone want to be extra cautious, I offer HIV PrEP for the partner. And anything else? Let's
I would
see.
think also that these conversations with these patients might be especially helpful to involve a partner or family members in those visits. Your examples, your case examples were really great illustrations of the stigma that might live in family relationships and come up for our patients with HIV. And so having them involved in those medical visits or behavioral health visits would give an opportunity to address some of that knowledge piece, address the stigma. But also, I would guess that probably partners and family members may also have a lot of questions or fears about what does this
Oh
mean
yeah.
for the person that I love who has this new diagnosis? What does it mean for our life together and their health and well-being?
Right, right. Yeah, I think the other piece is the mental health. I think
Hmm.
that's pretty much relevant to you all. I think if they have underlying mental health conditions, especially, they had to, they become at a higher risk for committing suicide because they feel like that's the end of it, and or
Sure.
they feel so shocked, and this actually happens quite a lot too. So you want to be extra careful and follow up with patient for their mental health as well. Mm,
Other thoughts and questions for Dr. Sonoda before we wrap up?
oh, thank you so much. Yeah, stigma is something I love to talk about in HIV and PrEP and addiction medicine because, once they come to our clinic, that's easy. If they can come to clinic as discussed, that's easy. But what happening is around the HIV and the addiction is like they just shy away from healthcare system because sometimes they're being treated in not the ideal way, and they build some mistrust around the healthcare. So I hope you learn something new, and you know you educate your colleagues too and create some good environment for all patients.
Absolutely. Well, it looks like we can wrap up there. Thank you so much, Dr. Sonoda. This was very interesting and I think will help all of us taking care of these patients and their families.
All right. Thank you for the invite. Thank you, everyone. Have a great day.
Bye, everyone.
Bye.